now at Dr. Sule, they've mentioned about cancer treatment, the chemotherapy, the radiation, the mastectomy, the breast reconstruction. Again, it's a team of doctors. And here comes a lady or a patient who has questions of, I'm going through chemo, I'm going through radiation. Can I still have an active sexual life? And not only active, but can I still enjoy sex?
Well, that's actually a really interesting question. The short answer is yes. The short answer is yes. And the thing is that cancer is not the end of life. Whether people are undergoing treatment or whether they've completed treatment, and as Dr. Odhiambo mentioned, they're cured, it's very, very important for women to be able to enjoy a normal and healthy sex life. It's important for them. It's important for their partners. Now, the reason why women tend to suffer a little bit in terms of female sexual dysfunction is because cancer patients, especially in third world countries, get very little information, very little support, and very little solutions to their actual problems. So even when they go and Google, and we allow them to, they find a solution and then they come to a doctor and they're like, that's not available in Kenya, I'm sorry. And so the information and the support and the solutions are actually not there. And of course, these conversations must be had because the cancer rates are increasing, the incidences are increasing. So at some point, we must have these conversations. And as both doctors have mentioned, multidisciplinary approaches and teams are very important because as much as I'll have a patient who tells me, look, I've had treatment and I would like to now, enjoy my sex life. Sometimes I'll still have to send her back to Dr. Odhiambo and say, look, have you, is this chemotherapy, for example, going to affect your sex life? Or is this radiotherapy going to affect your sex life, and how? So the short answer is yes, it's possible, but it requires a multidisciplinary approach. You cannot treat a cancer patient alone. Mm-hmm. You cannot treat a cancer patient alone as a doctor, and it's not fair to the patient and her outcomes or his outcomes as well. So yes, it's very possible. There's very many solutions and things that can be done. Yeah.
Even when you're going through the treatment, even when I'm going through the chemo, the radiation.
Yes, before and after the treatment. Okay. Yes, it's possible.
Have you met patients who sometimes their partners are afraid? Because I've seen them going through this process, they're too frail. There's the fear, I don't want to ask that of my partner. I don't want to touch them. Sex is the last thing we should be talking about. Do you have is that a valid fear? Because we have a lot of fear all around. Is it? Have you seen that maybe?
Yes, many times I've seen it. It's a very valid fear. People don't want to bother cancer patients. Mm. They have a lot on their plate. They have the fear of death. Mm. They have the, questions around, survival, questions around the effects of the treatment that they're going through. So their partners don't want to be a burden to them and start adding sexual needs as another list of things that, is required of them. They already have so much on their plate. And frankly, for me, this is possibly the saddest part of my work. My work is generally happy, and these other two doctors, my work is generally happy. But at the end of the day, cancer does need to be dealt with. So for me, my approach is always, how can we get you back to normal, back to the way you used to be, back to, if nothing else, maybe not 100%, but being able to get as close as you can to the baseline of how you used to enjoy sex, how you used to live your life. There are times it's absolutely not possible, but there are times it's possible. And so we do get a lot of partners who want to request certain things for lack of a better word, but they're not able to because of, shyness and because of how much is on the plate and how much is on the line. I usually encourage them to express their needs, possibly in a polite and gentle and supportive manner, because actually it's very encouraging to a partner that the other partner still actually wants to enjoy a sex life with them. Sure. It actually boosts their confidence that, despite cancer, my partner still wants me. It's very, very important for them to actually hear that and to have that kind of emotional support, as long as it's not, overbearing or forceful in any kind of way. Yeah.
Okay. And as you're going through this treatment, is it possible to experience sexual dysfunction as women? Is it a side effect of the treatment?
Yeah, it's very possible. It happens a lot. And some of the things that women experience are like anorgasmia, inability to achieve an orgasm. Some women experience painful sexual intercourse because of certain treatments that they're going through. Some women experience fistulas, for example, a communication between the bladder and the vagina, a communication between the rectum and the vagina because of the cancer treatment that they're going through. Some women experience just low libido, arousal disorders. And of course, there's the emotional part of it, where women who are undergoing cancer treatment or have had surgery for cancer have a distorted body image, low self-esteem. Just even for those who are actually able to have sex, many of them are not able to have sexual satisfaction. And so there's very many things that will now comprise female sexual dysfunction for patients who undergo any kind of cancer treatment. And of course, the causes of this female sexual dysfunction is the actual cancer treatment, other than the emotional state that they're in. So surgery itself can cause a female sexual dysfunction. For example, if a patient has vulval or vaginal cancer and I have to go and take out half of her vulva, of course she's going to have sexual dysfunction. She physically cannot perform, but also aesthetically her self-esteem will be down because the external genitalia are, basically missing. The chemotherapy itself can cause low libido because it does affect the ovarian function. It affects how our ovaries produce estrogen and progesterone. And so libido will definitely drop for women. At the same time, even the immunotherapy, as Dr. Odhiambo was mentioning, and all other hormonal therapy, because we do have hormonal therapy even for breast cancer as part of breast cancer treatment, that does actually affect female sexual dysfunction. The partner really feels not just ashamed, but also embarrassed and also overbearing to make such demands. It's really possibly not the time to be asking that. But I think there are ways for that life to be maintained. And honestly, sex is one of those things that releases lots of endorphins. So sex is actually healthy. So even just for the general well-being of the patient, it may seem like the wrong time, but I think it's a pertinent question. And also partners need to learn how to address these questions between each other. So for example, if a cancer patient had their partner, express this kind of need, she'll be like, I have so much on my mind, you're here asking about sex and me, I'm here dying. That's not how it works. There are ways to have this conversation so that both partners are comfortable and also so that the relationship maintains. Because remember, there's a lot of partners who leave a relationship once a diagnosis of cancer is made, no matter what diagnosis that is, whether it's colon cancer and someone has to live with a colostomy, or whether it's breast cancer and one has to lose their breast. A lot of relationships end after a cancer diagnosis. So if these talks are had in a healthy manner and in a supportive manner, a lot of relationships can actually continue beyond the diagnosis.
Yeah. And so patients who have the diagnosis of cancer and they're going through treatment, it is not an unfair request to ask from your partner. And do not feel guilty when you want to have a sexual life with your partner. Like you've heard from the doctors, it is possible. They were all shaking their heads. So I believe it is possible to have a healthy sexual life. I don't know, the gentlemen, if they have anything to say on this topic. Do you want them to say something?
If they have comments. Happy to hear.
As both the ladies hear this, the gentlemen have to say something. He had a very good point and I don't want to miss that.
So a lot of times when I'm dealing with young couples, and either the guy or the lady has been diagnosed with cancer, then sex is no longer a conversation that they have because, as Kristina said, there are many more serious things. So how can we start talking about sex? So they don't talk about it. So immediately there's no sex. And then they're happy that way. So from time to time, I do ask my patients, are things in the bedroom okay? Do you need any help? And then they're shocked, like, you can still do these things and you have cancer. And I'm like, yes, you can. It doesn't stop you. Ask your doctor when is the right time.
Yeah.
For example, there are some types of chemo. We'll tell you 2, 3, 4 days after chemo, you can abstain because it's still circulating within. But after that, between the second all the way to the third week, it's okay. But remember, we also don't want you to get pregnant in between chemo. So there are precautions which Dr. Kristina can tell you need to take so that you don't get pregnant either during or immediately after. But it's a conversation that needs to continue. Being diagnosed with cancer doesn't mean that you throw sex out of the window. No. Just talk to your doctor, get the correct information, and then you can just have a happy sex life.
You bring me to the question, if I would think about myself as a woman, if I've had a cancer diagnosis, I've been treated, or in the process of having treatment, does it mean my ability of my options of becoming a mother out of the window? Can I get pregnant? Can I give birth? Is that a conversation that can be had?
Yeah, that's actually a very important question, because sometimes cancer diagnoses are made very early in life, either before people had children or when they weren't done having children yet, and they still need to be able to fulfill that part of their life. So in short, yes, it is possible to continue either with pregnancy or childbearing through that diagnosis. Certain cancers are not even as aggressive, and women are able to receive chemotherapy during pregnancy and are left unaffected, and their babies are left unaffected. It's actually some chemotherapy forms, as Dr. Dembo will tell you, are actually quite safe during pregnancy with very low risk to both the mother and the baby. And that's when the diagnosis is made during pregnancy. There's some diagnoses that are made after pregnancy, but in between childbearing. So many times people are able to undergo chemotherapy and get either cure or go into remission and are able to have a pregnancy in between. The thing is, we don't want pregnancy happening during chemotherapy. Once, if it hasn't happened already, it's not a good time for it to happen. But yes, it's quite possible. Women also have the option of cryopreservation, which is a really, really important option. And I personally love cryopreservation because it stops time for a woman and it releases pressure. She's able to save her eggs and then plan for the pregnancy without thinking, oh my goodness, now I'm 40. Oh my goodness, now there's cancer. Oh my goodness, I had to have a hysterectomy. Because even with cryopreservation, even after having a hysterectomy, for example, for cervical cancer, you can still have a surrogate and still have a biological child with freezing your eggs. Cryopreservation is freezing eggs, by the way. Sorry, I forgot to mention. So freezing eggs. So once you freeze your eggs, all time stops and all pressure stops. And you want to be able to come back at 42 and use your 30-year-old egg, which is a good quality egg, to be able to have a baby, or have a surrogate carry for you a baby if you had to lose an organ, or maybe you just don't want to be pregnant, because that's your choice as well, but you want to have a baby. So your reproductive health should be facilitated by your doctors for it to continue despite cancer diagnosis.
Wow. For doctors who are in this field, this information is obvious.
It's not.
It's
actually for most doctors don't know that, especially because I deal with chemo, that chemo can lower your ability to get pregnant in the future, and there are things we can do to you to reduce that probability. Before you start your chemo. So like all my young patients, we go through the discussions, and then we offer you an injection that literally stops your ovaries from cycling.
Oh, that's amazing.
Yeah,
That's amazing.
That's
so
really
throughout
important.
chemo, you're like in menopause, and then in fact, I had a patient just last week. Like it's barely 2 months since she finished chemo, and she's already pregnant with the first baby. But we had to go through that process before, because the type of chemo we were using has a slightly higher risk of her becoming infertile. So she's happy.
That's really important.
That's really important for you to know. Dr. Sule, if for example, as a woman, I have a sexual dysfunction because of the treatment, are there options and what are the solutions?
Yeah, there's a number of options for women who develop female sexual dysfunction during cancer treatment of whatever kind. First of all, it's important to identify what treatment they're going through, because different treatments give different forms of female sexual dysfunction. For example, radiotherapy, especially for reproductive health, can cause something we call vaginal fibrosis. So the walls of the vagina with radiotherapy become very thickened and become they lose their elasticity. As Dr. Hungu had mentioned, it's where they contract and become very rigid. And of course, nobody wants a contracted and tough and rigid vagina, but there's solutions for that. So sometimes for women, we are forced to use dilators, and so the same dilators that we use for vaginismus, we get medical grade silicone dilators, and we allow women to use them gradually over time so that they can regain a bit of the elasticity in the vagina and expand it a little, because it contracts and becomes very thin and tough and becomes very painful to have sex. So dilators are a good option, and these are just simple solutions to start with. Lubricants are also a very good option, which are very inexpensive. Lubricant costs really 100 shillings, and that's very important for women who develop vaginal dryness during chemotherapy or radiotherapy. We also have different radio frequency treatment, and radio frequency is not to be confused with radiotherapy. Radiotherapy is cancer treatment. Radio frequency is thermal energy. For example, the EVA treatment, you've had it, Catherine, so you know, and that can be used for patients who have vaginal dryness after chemo or radiotherapy, and that can stimulate collagen production, stimulate blood vessel production, and of course, whenever blood vessels are produced, nerve endings become extremely sensitive, and so with new blood vessels being produced, it restores the sensitivity in the vaginal wall so that women are able to still enjoy sex following or during treatments. Really important. In other countries, they also perform laser vulvovaginal rejuvenation for patients undergoing cancer. I personally don't use laser because I find it a little bit harsh in general, so I use radio frequency instead, but laser is a very good option in other countries as well. We have women who have to go through pelvic floor physiotherapy because, you know, the pelvic floor has been destroyed following the chemo and the radiotherapy. Right now we have very many pelvic floor physiotherapists in Nairobi. They do a really, really good job in restoring the pelvic floor. Some women have to go through low dose vaginal estrogen application. And the reason why I'm stressing that is because estrogen in general is a really big trigger for breast and endometrial cancer. So for women who undergo this, it has to be low dose and it has to be in the vagina only. You shouldn't take oral estrogen, especially with cancers like breast cancer. Cancers are very sensitive to particular hormones, but a low dose of an estrogen gel can restore the health of the vagina following this treatment and can be really beneficial. We also have patients who undergo, for example, platelet-rich plasma therapy. You may want to have PRP. You may want to have vaginal PRP injections just to be able to restore the vaginal walls, restore their integrity, their collagen production once again, their blood vessel supplies. So there's good therapy that's available for women who are undergoing this that can actually restore their sex. Like, they don't have to say, you know, put sex at the back of the list of, you know, things they want to achieve while going through cancer treatment. They don't have to shelve their sex life. They don't have to, you know, dump anyone or stop their relationship. They can actually continue with a fairly healthy sex life as long as it's, you know, physically possible. So there's lots of solutions available in Kenya.
Available in Kenya. Kenya, and you can have a new relationship.
Yes.
You don't have to say you start with it through cancer. Sorry guys, I had to make you guys laugh.
Is breast cancer only for women?
No, actually we forgot that.
Yes,
Eric.
No,
it's
not only for women.
Yeah. Neither is sexual dysfunction. Men get it as well.
Do the men want us to speak about?
Just my brief experience. Okay, first of all, men also can get breast cancer. So they still need to be vigilant. And you see, for men, since there's no, like, a lot of breast tissue, so any small abnormality in your breast should arouse suspicion. It will not just come like an ordinary breast lump most times. So men can be checked, and men can also be treated the same way women are treated. For male sexual dysfunction, it's also a big deal. aside from the emotional issues and so on, it's mostly erectile dysfunction and problems with ejaculation and that whole
And libido.
spectrum. And libido as well. And because some of the main treatments like we use for prostate cancer, they immediately cause those problems. And so some men even refuse treatment and say,
Because
I would rather eat this thing, let it kill me, but let me remain
yes,
A man.
a man.
Yeah.
And there are solutions. We work with the urologist. There are many solutions from tablets to implants to gadgets to many things that can help them restore that sexual life. So it's a problem, and there are also solutions, but we normally work together with the urologists to help us to sort their issues out.
Okay. And for Dr. Eric, if I'm a woman and I already have breast implants, same as male breast implants, the implants, and I come and now you need to do breast surgery, and the fear of losing my implants and having to go through the process all over again. Is there is there that?
And just to add to
Yes,
Kathy's
yes.
question, how do women with implants screen for breast cancer?
Yes.
Like, are they at more risk of missing a diagnosis because they have an implant as opposed to a woman who just has her natural breasts?
Yeah. Okay. So starting with the last question, screening, ladies who have implants. So the recommended standard for screening breast cancer, and as per globally and local guidelines, is usually a mammogram. But if you have implants, it's not very possible to do mammogram. So we can recommend MRI imaging, and you're able to pick up any issues in the breast tissue. As for someone who has implants and then gets a diagnosis of breast cancer, personally, I haven't come across any, but there are solutions to that, because if we need to remove the implant, then we treat the cancer and then we can put in another implant. So at the end of the day, because like I said, for cancer treatment, the priority is to cure the disease. Then secondary is the cosmetic appearance. So we can remove the implant and then treat the cancer. If it's a nipple sparing, skin sparing, or it's a mastectomy, then we can put in another implant.
Okay.
Yeah,
So it is possible.
it is possible.
Maybe one last question before we close this YouTube video. Dr. Ari, I'll ask a question, the medical oncologist. As a woman, a man, if I'm going through chemotherapy, radiation, there's also hair loss, which it's something that happens. Is it something that you experience with your patients when you treat them? It's something they're worried about, concerns?
I think that's a very pertinent question, and it worries most patients. You get patients who have had dreadlocks, and they consider them part of them. They've had them for so many years, and they have to undergo chemo, which sometimes can cause hair loss. It's very traumatizing for them. In fact, that becomes a bigger issue sometimes than even the cancer itself, because they'll worry about how they look. Not all chemos cause hair loss. So that's a myth. Most people, they imagine that any chemotherapy will cause hair loss. Not all chemos cause hair loss. Some, the probability is higher, some it's mixed, and some do not cause any hair loss. So just discuss that with your doctor. There are methods to try and reduce the hair loss for some of those chemotherapies that we use for breast cancer. But that technology is not yet available in the country. It's called scalp cooling. So during chemo, we put a cold helmet on your head, and it is thought that if we reduce the temperature of your scalp during the chemo, then we can reduce your chance of having hair loss. So in the UK, it was a very big deal, and people had to book the scalp cooler many weeks before their session. It wasn't available for everyone, and it doesn't work for everyone. But the take-home point is you could lose your hair, but 3 to 6 months later, it grows back, and it grows back well most of the time. There are now hair specialists who can also help that healing process of the hair to be better. And most of my patients who've been cured for breast cancer, and it's now 2-3 years later, have all their hair back.
As a patient who's been diagnosed with cancer, I would ask myself a question before I even walk into your rooms or even after the first session. And here you're coming with a treatment plan, a diagnosis, follow-up even after we've seen there's follow-up. A treatment is a journey, and we need a team of doctors. Does insurance cover? Does our insurance cover?
Okay, so in our various specialties, we interact with insurance differently. So for me as a surgeon, with the diagnosis of breast cancer, it can cover treatment for the cancer, the radical treatment. But when it comes to reconstruction, again, insurance falls into two categories, private and the national scheme, the NHIF. So for private, when it comes to the reconstructive options, you find that it is not covered. They classify it as cosmetic surgery. And as cosmetic surgery, they have an exclusion for that. So that's a big challenge. And if it is an implant-based reconstruction, then the implants have to be sourced by the patient themselves directly to the supplier. And that cost is not going to be covered by insurance. If it's a flap reconstruction, insurance might cover up to a point. Because again, the surgery is long, it's multidisciplinary, so then the costs are likely to go higher in a private facility. Now, NHIF, I can't comment too much about NHIF because it's a very broad topic. Sometimes it gets opaque, but
It's a topic, yeah.
But NHIF, funny enough, has no exclusions, to the best of my knowledge, but still, implants have to be sourced by the patient themselves. So insurance cover for cancer patients, and especially the reconstructive bit, is a very big challenge that we face, and I think it's something that needs to be addressed.
Needs to be addressed. I think
At policy level. Yeah.
Yes. Right.
I think for me, what I could tell the viewers is cancer is an expensive affair. You need to have insurance. If you have the chance of getting a good insurance now, get one early. If you don't have NHIF, get your NHIF sorted out. It will really help to reduce the financial burden of cancer treatment, especially chemotherapy and radiotherapy. If you're getting a private insurance, let it be very clear what it will cover you if you get diagnosed with cancer, and then what would happen at the point of renewal. Those fine prints are left very small and very hazy. You could be walking around with a 10 million cover, but they haven't read the fine print of the policy document, which sometimes could state that chronic conditions of which cancer is included, then they only cover you for maybe 1 or 1.5 million per year. So if you're getting a private cover, be very careful. Look at the policy document, or have your lawyer or your HR go through it so that it's clear how much are they covering you for chronic conditions for the year, and upon renewal, what will be the terms going forward, so that you don't get surprises. We get surprises many times when it's crossing over to January, and then all of a sudden you have no insurance.
Yeah.
So have a good insurance, have NHIF. All those are useful, and they really help us to treat our cancer patients because they really pay. And most insurances are good. They'll sort you out.
Doctor.
In my experience, it's just to reiterate what Dr. Hungu and Dr. Dhiambo were saying. So, for example, patients who have vulval cancer or cervical cancer, the insurance, both local and international, are going to cover for like radical surgery for cervical cancer. It's called a wartimes hysterectomy. They'll cover for that. They'll cover for vulvectomy. So they're likely to cover that. But the problem is, once again, reconstruction. Reconstruction that may need to be done by any gynecologist, but specifically a cosmetic gynecologist, is not going to be covered. Reconstruction meaning, just surgery to improve the outer appearance of the vulva so that it's not disfigured following both surgery, chemo, and radiotherapy. For example, if we needed to do autologous fat grafts, we want to transfer fat from another part of the body into the vulva that had undergone chemo and surgery, and now we just want to make it look as natural as possible, that's not going to be covered. If we wanted to put a synthetic filler into the vulva after it has lost shape or lost a significant amount of fat following any of those processes, once again, it will not be covered. And it's really something that insurance companies need to look into, both local and international. I've had exceptions for reconstruction for some international covers, very few, but it has to be a very solid cover. Your employer must be involved and say, look, if any of my employees has to undergo cancer that needs this surgery, please include reconstruction as well. And you see, those are not only fine prints, but those are like special arrangements, which should not be the case. It should be, this is available to anybody who has to undergo this kind of cancer treatment. It should not be exceptions. It should be the rule. So reconstruction is very difficult to get under an insurance cover, but the basic treatments, which are the life-saving ones, are usually available.
Yeah.
Thank you, Dr. The information is power. And you have to give
Do
them
like
the
insurance
information.
companies run away from you when they see your title, Cosmetic? Can you call it?
I don't put it in my insurance forms. Yeah, I just put OBGYN because immediately you add that question.
That's
it.
But also patients know that as well, which is a good thing for me because when they come, they know it's not gonna be covered.
No, it's the patients are very rare. It's not going to be
Yeah.
covered. Usually patients, like you mentioned, it's not an emergency.
Exactly.
So, they come, they plan, they
mean,
save, they live in,
Insurance companies are crazy. For example, if you had to do a vaginoperineoplasty following a 3rd-degree perineal tear after labor, really, this is not a luxury surgery. This person had a baby.
Yeah.
This baby destroyed the perineum. Maternity is in your cover. Why should that surgery not be within your cover? Now you're calling it cosmetic. So someone is supposed to walk around with a damaged perineum because you consider. I mean, insurance companies are just
It's a con.
they're insane.
It is.
It
But
is.
it can be a lifesaver.
It can be.
My take home, myself, and I'm sure the people who will be watching this, there's so much hope. If today you get a diagnosis that you have cancer, there's hope. We have qualified doctors. You can get treatment in Kenya. It's not a death sentence. And thank you, Dr. Aris, for being here. All the 3 doctors.
Thank you for
Dr. Sule. And Dr. Aris, before we finish, would all the doctors maybe mention where they practice the clinic they practice in? If my viewers want to get in touch, they know someone who needs your services, we'll start with you, Dr. Eric. Where do you practice your clinic?
So my clinic is at Nelson Awori building, 5th floor, room A1. We actually share an office with Andrew. But I also work at Kenyatta Hospital. Yeah, so for some of my patients, if they opt to come to Cambridge, they'll find me there.
Okay.
So as Erica said, we sit in the same office
Okay.
at Professor Nelson Awori Center, which is just behind Nairobi Hospital on 5th floor, room A1. I also practice at Kenyatta Hospital, also Nairobi Hospital and Coptic Hospital. We tend to move around quite a bit because of the nature of the work we do. But that's where you can find us.
Okay. And we all know you can find Dr. But for those who don't know, you can please feel free to let them know.
For those who don't know me, I practice at Alora Medical Practice, my private practice in Upper Hill, in Fortis Suites, 6th floor, room 601.
I hope you guys enjoy the video. I'm so happy, Dr. all of you, for coming and gracing and taking your time. This is truly free consultation. It's an early Christmas gift. Thank you very, very much. As I always say, information is power. And I hope you all learn from this video. And feel free to reach out to any of these doctors. And like they mentioned, if you want to reach out to them, you can reach out to other doctors. And cancer is not a death sentence. Until next time, bye-bye, guys. Bye. Bye.